all of you for this important event. I would like to announce two important things. I kindly request you all to switch off your microphone and the videos until you finish our lecturer, resource person finish the lecture, and at the end of the lecture we will take up all the questions and you can ask questions from the resource person directly. You can switch on your mic and the video. So the lecture time would be 45 minutes. At the end of lecture, you can ask the questions, and or even you can type the questions. Without wasting our time, so I am going to introduce our lecturer. She is Udya Rodrigo. She is a product of Faculty of Medicine, University of California. She obtained her MBBS in March 2004 and then opted for postgraduate training in anesthesiology. She obtained her MD anesthesiology in year 2013 and completed her local training in National Hospital, Colombo, as well as a teaching hospital, Kaluboville. Then she was posted to overseas training, and she had a chance to get her overseas training in UK. Raymond Hospital in United Kingdom, and after completion of her foreign training, she obtained her postgraduate the board certification in critical care medicine in year 2016, and currently she is holding a post consultant in critical care medicine, North Colombo Teaching Hospital, Ragama. So as we all know, that the most difficult part in the management of the COVID pneumonia and the COVID related illnesses is the ICU care. And I'm sure that she has much experience, and she will enlighten us on her experience and the COVID management in ICU setup. Without much wasting time, I would like to, on behalf of the President and the Council of the Uva Clinical Society, I would like to cordially invite you, Dr. Udya Rodrigo, to deliver her lecture. Over to you, Udya. Thank you.
Good evening. Thank you, Dr. Bandasiri Ratnayaka, for that very kind words of introduction. So today I'm given a topic, this topic to discuss my experiences in managing the COVID pneumonia in ICU setup. First of all, I must say that I'm representing the Ceylon College of Critical Care Specialists in Sri Lanka, one of the youngest specialists in the field. So I thank the organizing committee for inviting us to represent in your academic forum. So moving on to the today's topic, the ICU management in COVID. So looking back, how we faced the pandemics in the past, way back in 20th century, where we had this polio epidemic. So there, the intensive care was initiated by providing this sort of respiratory support called iron lung ventilation. So since then, the intensive care field has gone through an enormous development up to now. And in the world, in the European world, intensive care has been established as a separate specialty way back in 1950s. And in Sri Lanka, the very first intensive care unit was started in 1968. So not too late compared to the European world. So today we are facing another pandemic with equipped with very advanced technology and the skills around us. And some of the ICUs are in the world functioning in a state of art fashion, facing this challenging situation. So this is where we are standing today. And now I'm going to share my experience related to the COVID management in the intensive care setup. So focus of my topic will be on the following subheadings: the oxygen therapy and the respiratory support available in the intensive care, and the fluid and vasopressor support given for septic patient coming with COVID pneumonia, and the evidence-based management of thromboprophylaxis in COVID, and then criteria for Ecmo referral. Since we have this facility in our country, I just wanted to touch that as well. And finally, the recommendations of advanced life support for COVID patients according to the Resuscitation Council guideline. As you remember from the last week lecture, that the previous speaker has elaborated on the COVID disease presentation and the pathophysiology and the evidence-based management in the primary care setting. From that, I'm going to move on to my territory in the intensive care management. Just to recap what you have already learned, there are 3 stages coming up. When it comes to the intensive care population, we have the advanced stage of stage 2 and the stage 3 phases of patients coming here. So I think the previous speaker has gone into details about these various treatment modalities with the current evidence behind that. And same principles we do practice in the intensive care unit. So I would like to take you through this case scenario and then discuss the management, sharing the experiences we had facing this challenge patient. My patient was 42-year-old man, young patient with no known comorbidities. However, he was in a sort of a morbidly obese category. He admitted to a medical ward being under duration with diagnosis of COVID disease. So on admission to the medical ward, he had a saturation of 88 on room air. However, during the course of ward stay, his condition worsened, and there we got the referral to admit him to our intensive care unit. So this X-ray shows the X-ray taken on the admission. So on admission to the intensive care unit, these were the vitals recorded. He was tachypneic with a respiratory rate of 40 to 50, and the saturation maintained with non-rebreathing mask about 92, 93. The blood pressure and the heart rate were towards the higher limit, and the sequential organ failure assessment score, that is some complex assessment of the dysfunction of the organ system that we do in intensive care, revealed 4 out of 24. So the initial investigations, as you can see, revealed there is a significant degree of cytokine storm, and the blood gas on arrival to the intensive care unit showed the partial pressure of oxygen to FiO2 ratio 175. There is one indices that we obtained from the blood gas to assess the degree of hypoxemia. So we started him on non-invasive ventilation, and the guided fluid therapy was initiated, aiming for a restrictive fluid arm, and the standard therapy as per the evidence initiated. And however, patient's clinical condition worsened, and the repeat blood gas findings revealed these parameters. So according to that, we found that the patient was becoming more hypoxemic, where the partial pressure of oxygen to FiO2 ratio came further down to 74. So knowing that we are going to face difficult intubation because of its morbid obesity and also short neck and the limited neck movement, we decided to electively intubate this patient. with taking all the adequate precautions. So that was on the day of third day of ICU admission. And the next day, we decided to give him interleukin antagonist, tocilizumab, as per the evidence coming from the recovery trial. This is the X-ray, as you can see. There is obvious worsening of the radiological features can be seen. So moving on to the little bit of factual details. So this patient's condition, now initially he came with the COVID pneumonia and progressed to a sort of respiratory distress syndrome. And conventionally, this acute respiratory distress syndrome was defined by this famous Berlin definition, came up in around 2012. So according to that Berlin definition, ARDS is defined as acute hypoxemia characterized by there is evidence of radiological changes along with some edema formation in the lung. So there the severity grading is further classified according to partial pressure of oxygen to FiO2 ratio. The normal ratio being more than 300. So mild, moderate and severe gradings are defined according to this cutoff values. And the severe grading is coming when the partial pressure of oxygen to FiO2 coming down to less than 100. So going back to our patient, so we had this blood gas on arrival. So that shows the patient was in moderate ARDS category. And then subsequent blood gas revealed that he was going into the severe ARDS, where we decided to intubate this patient. So there are various risk factors are identified related to this novel disease, and that shows the severity of disease and the fatality. And obviously, the advanced age has a very high tendency to give bad outcome, and also high sequential organ failure assessment score that gives an idea about the number of the dysfunction and the severity of the dysfunctions of the organs involved, and the comorbidities such as diabetes, hypertension, and ischemic heart disease, as well as patients on various medications such as angiotensin enzyme inhibitors have high chance of giving rise to disease, high disease severity. Also, the laboratory findings such as presence of lymphopenia and the degree of myocardial injury and end organ damage in disease, and the elevated inflammatory markers shows there's a high degree of organ damage associated with this disease context, and also the D-dimer level. As you can see, when the increased progression of the disease, you can see the severe and the critical stage approached. You can see the cytokine storm can be indirectly assessed by various inflammatory markers that we assess in when we are managing these patients. Coming back to the pathophysiological changes identified related to the COVID disease, as compared to the conventional ARDS pathophysiology, there is a distinct three types of pathophysiology of the lung behaviors identified by Gattinoni. Is one of the intensivists in Germany, and together with his team members identified these three types of distinct lung behaviors. Those are called phenotype L, H, and F. So the changing of these phenotypes are depend on the inflammatory response and the stage of the disease, as well as the patient's mechanical response. So the initial one is the L type, that in other words, low elastance type. The elastance, that in other words, that is the resistive properties of the lung, opposite of the compliance. So that is very low in this L-type lung. So in this category of patients, even though they are having hypoxia, the work of breathing remains normal. So you classify them as having silent hypoxia or well-known happy hypoxic stage. Moving on to the H type or high elastance type of the lung damage, there you see the classic ARDS type of alveoli damage. So this is enhanced by increased self-inflicted lung injury, and there is increased alveoli edema and the reduced compliance, and so that kind of severe hypoxemic stage will arise. And coming back to the fibrotic stage, so there is a definite permanent damage is done due to fibrosis formation. So as intensive care physicians, what we are mostly interested in is L-type and H-type. The reason that when it comes to the fibrotic state, there is limited scope for us to manage this patient. So according to the Gattinoni's observations and the recommendations, they recommend for the L type of lung behaviors to manage with the high flow oxygen, CPAP, and non-invasive ventilation for non-intubated patients. And if patients requires intubation, you can manage with the conventional method of ventilation with relatively higher tidal volume and PEEP up to 10. And the prone ventilation is not so encouraged for this type of lung behaviors. Coming to the H type of lung behavior, there you get the classic ARDS type of lung damage, where you have to apply all the ARDS net lung protective ventilation strategies along with the prone ventilation to manage these patients. Coming to the practical facts about the oxygen therapy in intensive care, we have various devices to deliver oxygen. So those are classified into variable performance oxygen devices and fixed performance oxygen devices. As you can see, the nasal cannulae, simple nasal cannulae and simple face mask, those are that we use in most of the time in ward setup. The delivered oxygen fraction cannot be exactly calculated. And then when you need increased oxygen requirement, we can use the Venturi devices as well as a lung rebreathing mask, where we can go up to about 90% to deliver oxygen in patients requiring high level of oxygen support. When you are managing a patient who in a hypoxic stage, you can start delivering the oxygen from the low level to the high level, or vice versa. So whatever it is, you have to assess these patients clinically as well as objectively assessment with use of blood gases and other parameters, and then apply the appropriate level of oxygen therapy according to these various types given in this graph. So we have low flow nasal cannulae, simple face mask, high flow oxygen delivered via nasal cannulae, and CPAP, BiPAP, and also in advanced stage of the disease, invasive ventilation. So there is a place came for the prone ventilation. Even awake patients we encourage to be on the prone ventilation for most of the time, because it has proven a very good outcome in improving the oxygenation in the lung. And as the last option, we have the Ecmo facility here. This high flow oxygen therapy came into practice, medical practice, after this famous landmark trial called Floral study, a French study which was conducted in 2008 to 2011. So they found there is increase. There is a very high chance of reduction of the intubation rate and the intensive care admissions of patients who were being treated with high flow oxygen. So since then, this practice came into the medical practice very commonly, and even became very popular during this COVID pandemic. So even in ward setup, this high flow oxygen therapy is being used quite frequently. And there is a theoretical benefit of giving this high flow oxygen for COVID patients. As you know that when the patients become more and more dyspneic, there is obviously self-inflicted lung injuries formed because of the large tidal volumes they are taking. So we assume that the high flow rates given by this special device may sometimes to a certain degree can alleviate this distress. However, we need more trials to get the best outcome in COVID setting. So there are various other devices that is being used in COVID, managing COVID patients, as you can see, CPAP, high flow, and simple face mask oxygen therapy. So what is the evidence coming from in this COVID population? A landmark trial has been conducted in the recent past in UK involving more than 1,200 patients. And this it is one of the arm of recovery RS trial. So their observation has been recently published on this particular on website, National Institute of Health and Research. So according to their observations, they have found that there is participants who received continuous positive airway pressure or CPAP were less likely to require invasive ventilation from COVID-19 as compared to the simple face mask. Also, they found there is no significant benefit of using high flow oxygen as opposed to the simple face mask. So that the same recommendations, they raise our concerns to rethink or reconsider of using the high flow oxygen in a time like this, a pandemic situation where the resources are very limited. However, we need more and more trials and evidence to get the best outcome related to this various therapies. If we have to intubate this patient with worsening hypoxemic condition, so the mechanical ventilation that we'll have to apply. The problem of mechanical ventilation is, even though it's a life-saving measure, which can minimize self-inflicted lung injury, so there are problems that we encounter with the mechanical ventilation. Some of them are ventilator-associated conditions or ventilator-associated pneumonia, and which is precipitated by ventilator-induced lung injury. So it has been always a question among the clinician whether to intubate early or wait till the last moment. Still, the answer is a bit debatable. So it's all depend on the facilities and the skills available in the unit to manage these patients requiring mechanical ventilation. However, we have the evidence from the ARDSNet work trial, where they recommend to practice lung protective ventilation in order to minimize the risk of ARDS-related lung damage. And also, in order to prevent the ventilator-associated pneumonia, there is evidence-based strategies coming up in the ventilator care bundle. So we need to apply all these measures stringently to control these adverse effects of this mechanical ventilation in order to get the best outcome. So if you, the ARDSNet lung protective ventilation strategies involve ventilating with low tidal volumes, 4 to 6 ml per kg, keeping the plateau pressure less than about 30-31 centimeter H2O, and also the modifications of this ARDSNet recommendations is coming with keeping the driving pressure less than 15. The driving pressure means the plateau pressure minus the peak pressure. And when you are ventilating a patient, with mechanical ventilation, you can use the PEEP and FiO2 titration charts as given by the ARDS network recommendations. This is the schematic approach for managing patients with ARDS. So, moderate to severe category of patients, we may need to intubate this patient, and the evidence-based this is to apply on the restrictive fluid management strategies, and again the ARDSNet recommendations, keeping the low tidal volume, accepting the permissive hypercapnia, and use of paralysis and prone ventilation in extreme cases, and rescue therapies to as for the lung recruitment, and final option being the Ecmo therapy. So this is the prone ventilation, which became very, very popular practice during this pandemic. Even though initially we practiced that for mechanically ventilated patients, now during this COVID pandemic, we encourage the patient to be on the awake prone position in order to facilitate oxygenation. As you can see on this diagram, the prone ventilation facilitates oxygenation by improving the lung compliance because of relieving the weight of the heart on the lung tissue, as well as facilitating the postural drainage of the secretions, and also even distribution of the ventilation with large lung tissue area as shown in this diagram. The practice of prone ventilation coming from this landmark PROSIVA trial, again a French trial which was published way back in 2008. So according to their observations, they found there is a significant outcome benefit of patients managed on prone ventilation with severe ARDS, where there is PF ratio less than 100. This is how we perform prone ventilation in intensive care. We need a lot of involvement of the staff, high skill, and also, even though this is a very beneficial technique, that itself has its own complications. So you have to, the intensive care team has to be very familiar and trained on this particular technique to keep the patients safely on prone ventilation. Usually we go up to 16 to 20 hours at a stretch with changing the neck position, neck and arm positions. We need very intense level of monitoring as shown in this multi-para monitor that includes invasive arterial blood pressure, central venous pressure, and essentially end-tidal carbon dioxide concentration. So in extreme cases of the COVID pneumonia, in refractory hypoxemia, there is no conventional therapy has proven any outcome benefit, there is a place for referring to Ecmo. So in a pandemic situation like this time we are passing through, it's questionable whether this Ecmo has any place to manage pandemic situation. However, one out of many might get benefit using by going through this Ecmo therapy. So the criteria for Ecmo therapy is led by this extracorporeal life support organization, which is the international organization which determine the various inclusion criteria for Ecmo therapy, and patients with otherwise fit and healthy patients prior to the illness with acute hypoxemic respiratory failure, advanced stage, you can consider referring them to Ecmo. The severity of ARDS is assessed for Ecmo eligibility is assessed by this Murray score. So Murray score consists of assessment of 4 parameters. That includes partial pressure of oxygen to FiO2 ratio and chest X-ray evidence of involvement in 4-quadrant lung field, and the PEEP level that we delivered by ventilator, and the compliance. So the total score is given out of 16, and what we have to calculate is the average score. So the maximum average score come up to 4. The score more than 2.5, you can consider referring them to Ecmo centers. So that is, as you know, it is available at Karapite. So eligible patients that you can refer. That's all about the respiratory therapy. I will just move on to the other heading, subheadings in a nutshell. The management of patient in septic shock, sepsis and septic shock who are COVID pneumonic patients, the evidence from the Surviving Sepsis campaign. As you know, they recommend the last guideline was updated in 2018 update. They recommend the other one care bundle resuscitation. If there are any junior doctors, I'll just briefly go through the recommendations. The free resuscitation up to about 30 ml per kg, and then obtain blood for cultures, and then obtain blood for blood gases for lactate assessment, giving antibiotics, measuring urine output, and then finally monitoring the again reassess the patient, and then if necessary the oxygen therapy, and if you exceed the fluid quota, you can consider starting vasopressors. So what is the evidence coming from this Surviving Sepsis campaign related to managing COVID patients? So they recommend to use relatively restricted fluid therapy for managing these patients, as there is obviously ARDS related increased pulmonary edema. So considering the recommendation, you have to consider going for a lesser target of oxygen, and maybe you have to decide starting with the vasopressor a little earlier. With regard to the type of the fluid therapy, they recommend to use crystalloids than other fluids, and they strongly recommend to avoid any other colloids to manage these patients. And out of the crystalloids, they prefer to use balanced crystalloid solutions such as Hartmann. And the vasoactive agents, they recommend to start with norepinephrine as the first line, and then add on the vasopressin or epinephrine as the second line. And if there is coexisting cardiac dysfunction, you can consider adding dobutamine. And then they strongly recommend against use of dopamine. And there are recommendations also coming for steroid usage, and they recommend to continue the dexamethasone 6 milligram dose or the hydrocortisone 200 milligrams continuous infusion as a therapy for steroids. So coming back to the thromboprophylaxis in COVID, so we have seen that in the COVID pathophysiology, there are significant effect on formation of the thrombotic events. Also, we have seen the patients coming to the critical care having increased tendency to bleed. So the similar kind of picture has been observed in the Western world, and they have recommended these recommendations with regard to the thromboprophylaxis in COVID patients. This recommendation is from the British Thoracic Society. So according to their recommendations, patients with no evidence of venous thromboembolism or other indication for therapeutic anticoagulation who require high flow oxygen or invasive ventilation should receive less than therapeutic dosing. So the published evidence would suggest no benefit of intermediate or standard dose thromboprophylaxis in these patients. We also have the recommendation from Sri Lanka that is prepared by the College of Hematologists. According to their recommendation, they recommend to start on prophylactic dose for mild disease patients who have a risk of venous thromboembolism, and moderate disease patient, again, the prophylactic dose. And these two category of patients you mostly see in the ward setup. And when it comes to the severe disease, they recommend intermediate dose, that is the enhanced dose, in other words, twice the prophylactic dose. And the established venous thromboembolism, obviously, you have to go for the treatment dose if there is no absolute contraindications. If anticoagulation is contraindicated, we have to consider mechanical prophylaxis. Going back to our patient, he developed multi-organ failure involving severe ARDS, type 2 respiratory failure, and we continued 4 cycles of prone ventilation. And also he developed cardiogenic shock with ongoing atrial fibrillation and acute kidney injury, which we managed by correcting the pre-renal causes and critical illness neuromyopathy. However, we were able to extubate him on the 10th day of invasive ventilation, and then we weaned him off and discharged to the ward with a state of quadriplegic state. And after investigating in the ward setup, he was discharged home after about 6 weeks. And we came to know that patient came back to the near normal level of the stage after about 10 weeks of the illness. So apart from the providing the organ support, we do take care of a broader aspect of caring the patients in the critical care. So it's a very challenging situation that we experience in the intensive population. So we have always prepared, keep our team prepared for any emergency intubations, and we apply the lung protective ventilation strategies. Like kindly ask for the participants to keep your microphones muted. And we do apply lung protective mechanical ventilations in all the patients going through the mechanical ventilation, invasive cardiovascular monitoring, and the bronchoscopies, percutaneous tracheostomy as to facilitate the weaning from ventilator, point of care ultrasounds and echo. Those facilities are available in most of the intensive care unit, and the renal replacement therapy that we have either renal continuous or intermittent hemodialysis, and early feeding is always encouraged, and transfer of critical patients in a safe conduct. And also we maintain very high standard of communication among the other specialties as well as from the patient's party. We do conduct multidisciplinary team discussions in relevant clinical settings that we are not very sure which way to manage, and also breaking the bad news in an appropriate manner. And finally, sometimes palliative care to arrange a dignified death to the patient in a peaceful manner. And also we take a great effort to maintain the ICU quality indicators, and we apply always in stringent infection control measures in order to maintain the high standard of infection control measures. And also we conduct audits and keep the record keeping, and also morbidity and mortality meeting to assess the progress of our management. So as always, the intubating a patient, a COVID patient, is a challenging situation. So in the intensive care unit, in a critical ill patient, this is the position that we have to maintain in order to facilitate the proper visualization. And also sometimes when you keep, some people has a preference to keep the patient completely flat. But some in the COVID hypoxic patients, they don't tolerate that position. So you do have to keep them in a steep, propped up position and to proceed the intubation. Actually speaking, this makes your task easier because of that position, it makes easy visualization to the glottis. These are the some of the essential tools that I considered became very essential and life-saving sometimes to manage this kind of patients in critical care. Laryngeal mask airway. Actually, the patient I mentioned, we anticipated, we encountered difficult intubation. And at that time, we didn't have the video laryngos at the premises. However, we managed to intubate that patient using the video laryngoscope. Until we get the video laryngos from the different ICU, we maintain the main ventilation using LN. And this endotracheal tube with subglottic suction has an evidence-based evidence-based fact in order to minimize ventilator-associated pneumonia, gum elastic bougie to facilitate intubation, and also this particular NG tube with guide wire. We encountered many times that we faced difficult to intubate conventionally used NG tubes. So this became a very handy tool that made our life easier in passing the NG tubes. And as also this is celled in the chest drain. As you know, the COVID pneumonia has a very low threshold to develop pneumothorax. So if you have this kind of tools inside the intensive care, even a medical officer who will be working in the intensive care unit, when properly trained, can easily insert this chest drain to relieve the pneumothorax. So in echo and ultrasound and CRRT machines now coming very popular in the intensive care unit to provide multi-organ support. So our staff, the doctors are very familiar to assess this fluids assessment using the ultrasound and also focused echo waves to assess the cardiac function, and also this ultrasound used for diagnose pneumothorax also became a very common usage to identify pneumothorax at the bedside rather than waiting for the chest X-ray to diagnose. Coming back to the resuscitation, the main the resuscitation guideline remains the same. However, sometimes you encounter the patients in prone position. So their recommendation is to, if only one rescuer is available, to continue CPR in the prone position until the help is arrived. And if there is a shockable rhythm, you can give 3 shocks at a stretch. However, they strongly recommend for the clinician to decide on the escalation of the CPR for particular patients beforehand, before initiating the CPR, as in other countries there is a place for DNA CPR. When it comes to other settings, it's a bit questionable, as our legislation is still not backing for this DNA CPR option. So coming back to the last slide. So if someone asks me, can we ever have any hope beyond Ecmo? So I can't say no. That's because the availability of this brilliant surgery, the lung transplant. This is one of the intensivists who worked tirelessly during the Indian pandemic, who ended up contracting the COVID pneumonia. Even the Ecmo therapy did not recover him. So this brilliant transplant team offered him the lung transplant, dual lung transplant, that he's back at home happily with his family today. So hope this facility will be available in our country soon. With that, I'm going to conclude my talk. So there may be questions coming up. So I will try my best to answer according to my experience. So this novel corona illness is a heterogeneous disease process, needs individualized and dynamic management strategy. So thank you, the organizing committee, for giving me this opportunity to deliver this lecture. So that's...
Thank you. Thank you very much, Dr. Rodrigo, for your comprehensive and concise, excellent lecture, which currently most needed for us as far as ICU care management is concerned. So I would like to start first questions by myself. Udya, what is your experience in Ragama, early intubation or versus the late intubation? Do you keep patient in NIV for a long time, and what are your targets, saturation? And when are you going to decide for the elective intubation?
Actually, in most of the time, when we get the patient to the intensive care, that is, they are passing the beneficial time. Sometimes they refer to us keeping them in the ward for a long time on CPAP and high flow oxygen. So when we intubated that kind of patient, the outcome we have experienced is not great. If we do receive the patients in the early phase of the illness, like the young patients, sometimes VIP patients we receive at the early part of the illness, and then we wait for about 1 day, keeping them on the BiPAP or whatever the oxygen therapy, and if increased work of breathing establishes, we decide intubating early, and that category of patients only we have recovered and extubated up to now.
The mechanical ventilation. So what range of target saturation you keep?
Yeah, around 90-92 range. Average 92. And the partial pressure of oxygen around 70. I can't hear you, Dr. Ratnayakar.
You hear me now?
Yes.
Yeah, okay. Udya, several questions are on my screen now. I will ask one by one.
Okay.
First question goes like this. COVID patient on oxygen with severe respiratory distress, type of blood gas like PF ratio less than 100, is it better to straight away give CPAP first, or do we have to escalate oxygen supplementation and then start high flow and wait before we think about CPAP?
That's a very good question. Actually, that question I discussed with one of my colleagues in UK working as a consultant intensivist. So before publishing this trial, online trial that I highlighted in my lecture, there was a very common practice to initiate on high flow oxygen therapy for patients who are having high work of breathing. So we have seen that these patients are taking large tidal volumes. So maybe applying the high flow oxygen therapy, because of the high flow rates, there is some degree of relieving the work of breathing theoretically. However, we need the evidence, more evidence to come in terms of the intubation rates and the other outcome benefits. But after publishing this sort of a landmark trial, I can say, because they have involved about more than 1,000 participants, and they have found there is beneficial effect in CPAP as opposed to the high flow oxygen therapy. However, you can apply your own experiences in managing these patients and the patient's tolerability. Some patients don't tolerate CPAP, and in that case, you can try both intermittently and see how the patient getting on. Again, I can't see.
Absolutely, you are correct, Dr. Rodrigo, because CPAP is a very cumbersome thing, and some people it's very, very difficult to keep on CPAP mask, and so they prefer to keep high flow oxygen. But some people they also don't like with that the flow rate and the nasal thing and the irritation. And the one practical problem we are coming across that when there is some nasal secretions, always this blockage of the high flow system, and we have to time put secretions out and or some nasal decongestion. So in your experience, Dr. Rodrigo, what is so you opted for prefer the for high flow or CPAP in
Yeah,
Ragama?
yeah, we have all the facilities available in our intensive care unit. What if the patient having like we have a very tendency to very low threshold to start on high flow oxygen therapy. However, if patients not achieving the target on high flow oxygen therapy, we commence CPAP. And the problem with CPAP sometimes, as you all have must have seen, there is in COVID pneumonia stage there is a tendency to form mediastinal gases. So the high PEEP may be contributing towards this clinical problem, formation of mediastinal gas and the pneumothorax. So in that kind of patient, we de-escalate to high flow. And then if we are unable to achieve the target with high flow, we start with minimum PEEP, CPAP, and then proceed in that line.
Question, Dr. Rodrigo. In delirious patient, to continue CPAP, is it safe to use midazolam, haloperidol? If yes, what are the doses?
For delirious patients, yes, as a rescue therapy, we will have to use haloperidol. So the dose, of course, depend on the patient's hemodynamic state and the cardiac function state. We can give sort of an inner, if the patient is going through a very aggressive state, you can give doses like aliquots 2 milligram at a time and see that whether the patient is responding. And again, if the patient is very difficult to tolerate keeping on the ventilator, you can start on low dose midazolam such as 1 milligram or 0.5 milligram hourly infusion after giving a bolus. And now we have better range drugs for managing delirium in intensive care. That is one of the drugs is dexmedetomidine. Maybe some of you all must have heard of that drug. That's a very safe drug which nicely controls this ICU delirium state. And also we have a practice to give very low dose of propofol to keep them in a very low sedated state.
Goes like this. Next question goes like this, Udya. How to identify self-inflicted lung injury in COVID patient?
As according to my lecture and the lung phenotype type as explained by Gattoni and his team, there are L type and H type. So self-inflicted lung injury cause development of H type where you see the radiological evidence. That is the classic ARDS type. In the L type, the patients are in a sort of happy hypoxic state. Even though there is ongoing hypoxia, low saturation, patients clinically remain stable. So silly state or self-inflicted lung injury state develops when they are approaching the classic ARDS type of lung damage. That is the H type of lung damage. There you see the radiological changes predominantly. And the work of breathing increases.
There's another question to you. In a patient with moderate to severe COVID pneumonia who is having high work of breathing on FiO2 100% and PEEP 7, will you consider intubation or try with high PEEP first?
A patient, patients with, can I know the background of the patient, like age and other comorbidities and the stage of the duration of the COVID pneumonia?
Say suppose it's not mentioned in the question. Say suppose Udya, so 39-year-old male with BMI of 35 in COVID day 10 and on maximum support, and so we put on NIV and start with PEEP 7 and pressure support 14, and so with that so that's the case like a scenario, and so where to go next? Go for intubation or keeping increasing PEEP or the pressure support in NIV?
So I would go PEEP up to about 10 to 12 and see how the response is. And if the work of breathing continued to increase, I will have a very low threshold for mechanical ventilation.
What sort of PEEP and pressure support you are going to keep?
That is, of course, based on the baseline blood gas. I would first start with the high support, FiO200 and PEEP of 10 to 12, and then see how the patient responds. And then to de-escalate the support, targeting my target saturation about 60 and target PaO to about 60, and then as per the ARDS network lung ventilation strategies, keeping the plateau pressure, trying to keep the blood pressure less than at least 35, but that is a very difficult thing when it comes to the COVID pneumonia. That is the most challenging thing that we encounter, keeping the blood pressure less than 35. Sometimes it goes up to more than 40, 45 range. It's very difficult to manage. So in that case, we try with optimum muscle paralysis, restrictive lung fluid therapy, and also maybe prolonged duration prone ventilation if that improves the condition. So those are the measures that we adopt in my practice.
So when patient need prone ventilation, and what is your experience and practice in Ragama? So how often you use it, or there is a better outcome and any survival the versus prone ventilation versus the supine ventilation?
Actually, in our experience that we experience even in conscious prone ventilated patient, there is a very significant outcome in terms of improving the oxygenation. When it comes to the mechanically ventilated patient, even though it's challenging, all the mechanical ventilated patients, the first thing what we do is we insert the arterial line, central line, and put them on prone ventilation. We go up until about 3-4 cycles and see whether this patient is responding. Non-responders, we sometimes consider not to go for any more prone ventilation after about 5 cycles. But usually the responders, they do respond even first and second cycles. And we have extubated, for early intubated patients, in my knowledge, we have extubated about 5-6 patients, but most of the intubations what we have done is late intubations, where the F-type, F phenotype fibrotic changes have established patients. So we have never recovered them up to now. But early intubation, we have a reasonably success outcome compared to late intubations.
How many ICU beds under your care, and how many?
We have, in the medical side, we have 5 COVID ICU beds, and then there are 3 more beds reserved for surgical patients, adjacent to the surgical ICU. So altogether, 7 beds. 7, 8 beds. Yeah. But the problem is with the staffing. So in the medical ICU, we most of the time maintain 4 beds because of the staffing issue.
Physically inside the patient, so one-to-one care? Or?
Obviously not one-to-one care, because we are at least one nurse stays most of the time in the inside the ICU. When they have different care to be given, 2 nurses combined, and some doctors and consultants all visits every day. Intensive care consultant, I have myself and another intensive care consultant. So one of us every day we visit the patients, and also one of the medical officer visits, and we do work with the nursing officers to get the patients work done inside the ICU, irrespective of our roles.
Dear audience, if you have any questions, you can straight away direct to Dr. Rodrigo. If you want to speak to her, you can unmute your speaker phone and can speak now. Right. So silent means they have understood everything. I would like to know about the tocilizumab usage in your practice in Ragama.
Actually, we had a very low threshold to give tocilizumab. It's not only the intensive care consultant. We collectively, with the input from the respiratory team, we have about 4 respiratory teams available in our adjacent hospital, Valisara. So we collectively make a combined decision with the available inflammatory markers and procalcitonin levels that we assess, and the severity of the patient's disease. And we have a very low threshold to give tocilizumab, provided that is available in the hospital.
Collective decision before giving toci. Okay.
Absolutely.
Yeah. Okay. Right. I think so. In the absence of any more questions, let me conclude this informative webinar lecture. On behalf of the council and the president and the council of the Work Clinical Society, let me thank Dr. Udya Rodrigo taking her time and preparing this very informative lecture and enlightening us about the current management of ICU care. Thank you very much, Dr. Rodrigo, for your excellent lecture and for your time. And actually, we learned a lot from you, and you shared your experience. Once again, thank you very much for your excellent lecture.
I take a little time to thank again for providing me this opportunity. A special thank goes to Dr. Udana Rathapala, consultant nephrologist and the president of Uva Clinical Society, very dynamic young person who is very interested in academic activities. He has been working very well with our college activities as well. So he's the one who invited us to represent this academic activities. I'm very grateful that the Uber Clinical Society is conducting your academic activities irrespective of the various obstacles facing with the pandemic. That's very encouraging fact to see. A lot of people have joined these webinars. Even I joined the last week lecture, very informative lecture. Even I learned a lot from that lecture. So hope I will continue listening to all your lectures in future too. Thank you, Dr. Gihan, for assisting me for the technical part. And also, last but not the least, a very big thank goes to Dr. Bansiri Radnayaka, Consultant BP, for driving me through this program. Thank you, and thank you all the participants for being with me during this discussion. Have a good night and pleasant rest of the day.
Kind words about our society, about our clinical society, and about our great colleague Dana Ratnapala. And I would like to thank all the participants for your for kind participation and for this important webinar. So let me conclude the sessions, and good night, everybody.
Good night and thank you again.